Hello, everyone. Welcome to the Center for Community Solutions webinar on Medicaid experiments, an overview of potential waivers in Ohio. My name is Loren Anthes, and I am a Public Policy Fellow with CCS in the Center for Medicaid Policy. I will be leading the conversation today. Welcome. With me today, I have our Research Associate, Kate Warren, who will be helping field the question and answer period of today's webinar, which will take place at the end of the presentation. She'll also be able to field any technical questions you may have during the slideshow. Please note, we will be providing these slides on our website and via email to all attendees. You may also find them in the chat box. We will be covering a lot of ground today. As many of you may know, the Ohio Department of Medicaid recently released two of the waivers that will be discussed, including Ohio's 1115 work requirement proposal and its 1332 innovation waiver. This webinar will cover those items, but we'll also take a look at two other waivers, including an Institutions for Mental Disease waiver and a previously introduced cost-sharing waiver known as Healthy Ohio. To that end, this presentation is meant to complement a recent report we published earlier this month, which you may find on our new website at communitysolutions.com. The presentation will start with some context, then dive into Healthy Ohio, IMD, work requirements, and 1332 respectively. This is meant to be a high-level overview of these policies, so please hold your questions until the end. Of course, we are more than happy to follow up with any additional technical questions you may have after today's event. Let's begin. First, a little bit of context. So why waivers? Well, since the passage of the Affordable Care Act, not all states have been embracing the policies that are contained within the Patient Protection and Affordable Care Act, most notably with the Medicaid expansion. Medicaid expansion after Supreme Court ruling became optional, something that Ohio decided to do in 2014. For any of you who may have been working in the State House at that time or who are interested in that policy, you may realize that a lot of the questions around Medicaid expansion still persist. And in many ways, where Congress has been unable to repeal the Affordable Care Act, states have been looking to experimental policies or ways to renegotiate their Medicaid program through experimental policies, most notably through the use of waivers. Waivers are something that have existed with Medicaid for a very long time, and there are a lot of different types. In fact, Ohio uses a lot of different waivers currently. You can see the long-term care system, for example, where there are the use of home and community-based service waivers as alternatives to institutional care as a good example. However, it's 1115 demonstration waivers, which have gotten a lot of attention recently, particularly as individuals use those waivers to try to increase personal responsibility. In this slide, you can see Representative Jim Butler, who has been very interested in this idea, or these ideas generally, as an element to reform, or a mechanism to reform, rather, the Medicaid program overall. He said, "We do not think that Medicaid expansion was a good idea, not because we were against people getting care and getting covered, but just simply because expanding a health care system that was out of control without reform wasn't going to work." So it's important to contextualize a lot of these pieces because this has been the mechanism through which the General Assembly has sought to try to right the wrongs from a policy perspective that they saw the federal government was implementing through the Affordable Care Act. You can see this most notably in the recent biennial budget. In the Senate and House, there is a single-party supermajority, which means that they can override the veto of the governor. So the governor, for those of you who may not know, has the ability to line item elements of the budget. So he can veto ideas, concepts, policies, funding associated with the budget proposal put forward by the General Assembly. However, given the current makeup, both the House and Senate having supermajorities, they can override those vetoes, and you've seen them use this in a number of ways. I pulled out some of those overrides, and I should note, too, that these overrides, by and large, focused in on the Medicaid program. Now, in order for an override to be successful, the House has to override it and the Senate has to override it in that order. They can also override at any time during the General Assembly, so that 2-year period in which a budget is constructed, there's still the opportunity to override any veto. You can see here that the House, for example, overrode the governor's veto around requiring the Medicaid director to implement Healthy Ohio again, but the Senate has not yet picked it up. It does not mean that the Senate couldn't pick it up, but it does not, law does not yet require the Medicaid director to pursue that waiver. So that's a good segue into Healthy Ohio. So what is Healthy Ohio? So many of you may remember Healthy Ohio is a cost-sharing 1115 demonstration waiver. It required individuals to contribute to health savings account or HSA-like Buckeye accounts. This would cover the costs associated with the plan and included a core portion, which equaled 2% of an individual's income up to $99 a year, and a non-core portion for which the state funded up to $1,000. Non-payment by the individual would lead to disenrollment. It also renegotiated co-payments. Co-payments were something that are allowed in Medicaid and technically are a part of Ohio's law, but tried to create incentives and disincentives for individuals to take part in the economic transaction of Medicaid by disincenting emergency room utilization, for example, and requiring very larger co-pays as opposed to, say, primary care. There was also a point system for healthy behavior in which points, 1 point equaling $1, so that individuals could earn incentives for following through on healthy behaviors. These points would be assigned by the doctors with whom they work and also by the Medicaid director. During the comment portion of this proposal, the first go-round, many people brought up the question of whether or not this violated Stark law or anti-kickback law because it would create incentives for individuals to utilize services. It also developed something called a bridge account. Part of the policy concept here was that individuals should be incented to transition from Medicaid or public insurance to private insurance. So where there was money left over in these Buckeye accounts, they could be transitioned to a bridge account so that individuals could afford, co-pays and other items within the context of their new private insurance. Now, as I mentioned, Healthy Ohio was submitted in 2016, and the Centers for Medicare and Medicaid Services, or CMS, stated the following. We are concerned about the state's request to charge premiums, regardless of income, to 600,000 individuals in Ohio's new adult group, that's Medicaid expansion, as well as hundreds of thousands of low-income parents, foster youth, and beneficiaries with breast and cervical cancer. CMS is concerned that these premiums would undermine access to coverage and the affordability of care and do not support the objectives of the Medicaid program. So this is, the reason I picked this out is to inform some of our thinking around why waivers are rejected or accepted or what policies are incented. And I'd like to highlight here that, first of all, this CMS was under the Obama administration, so they had a different interpretation of what waivers were for. And specifically, they said that coverage and access to coverage is a key tenet of the Medicaid program. And also highlighted some of the policy concerns that people brought up. There hasn't been a cost-sharing waiver that was accepted, for example, where individuals below 100% of the federal poverty level would have to contribute. Also, by the way that the law was written, it affected women with breast and cervical cancer, foster care youth, and other folks, which I don't think CMS would support. In the last biennial budget, we talked about the veto process earlier. The veto message from the governor said, basically, this provision mandates the Department of Medicaid to request the same waiver as it did before. And we share those goals of increasing our flexibility, but if seeking an identical waiver may not work. But we are interested in pursuing these sorts of reforms. So the governor is basically saying here, like, hey, General Assembly, we hear you, we understand. We don't think that this specific waiver as outlined in law is going to work for CMS or is going to work for us for a number of reasons, but we want to work with you on personal responsibility measures. So you haven't seen the Senate yet take up the House's override. They still have the ability to, but what's key here is that there's currently no waiver that's being pushed forward to require Healthy Ohio specifically. Moving on to IMD, or Institutions for Mental Disease. So a little-known 50-year-old federal law, the Medicaid Institutions for Mental Diseases IMD exclusion, has come under increased scrutiny as the death toll associated with the opioid epidemic continues to climb. The rule has been blamed for limiting treatment options for persons with substance use disorders, or SUD. The exclusion is in Section 1905 of the Social Security Act, so this is something that's been in there basically at the founding of Medicaid, and prohibits Medicaid payments for care or services for any Medicaid beneficiary under the age of 21 or over the age of 65 who is a patient in an institution for mental disease. Traditionally, that means that states are responsible for inpatient behavioral health. The reason for this is multifaceted, but part of the reason here is that the federal government didn't want to continue a sort of legacy of institutionalization for individuals with mental health issues. That being said, especially with the opiate crisis taking place, states have looked towards this policy and said, is this not an opportunity for us to increase the treatment options available for individuals with substance use disorders? And indeed, you've seen that there are a number of waivers proposed by the majority of states, although, Medicaid is a program that also extends to territories. 15 have been approved and 11 are pending as of November 2017. Out of the 15, only 8 are for payment in an institution for mental disease, and 7 are related to substance use disorder, and only 1 for mental health. Out of the 15, the 7 that don't have to do a payment often includes things like eligibility expansions or delivery system reform, ways to prop up, say, community behavioral health. CMS put out guidance on the IMD exclusion, the current incarnation of CMS, this past November. It encourages the use of 1115 waivers for the opiate epidemic, but also stresses the need for budget neutrality and a full continuum of care. We talked about institutionalization before. One of the things that the federal government has highlighted and many advocates highlight is the fact that you need to have a robust system of community-based supports in order to be effective. You can't just provide inpatient or residential treatment only. So CMS is interested in exploring these options, but wants to see that it's fiscally sound and that it's connected to the community. One thing to highlight here is the managed care rule that was developed in 2016 by CMS. It allowed states to pay for IMD services outside of IMD. So this is a bit of a departure from traditional policy. The enrollee has to elect IMD services as an alternative to otherwise covered settings. The IMD is a hospital providing psychiatric care or inpatient care for SUD, or a subacute facility. Sometimes that can include nursing facilities, providing psychiatric or substance use crisis residential services. And the stay in the facility is for no more than 15 days in any calendar month. However, a beneficiary can stay a total of 30 days as long as it occurs over 2 months. Something to highlight here is why 15 days. CMS did a multi-state statistically based project to try to determine what's the appropriate length of stay for something like this. And in that context, they found that the average stay was around 8 days. Now, some have criticized saying that, well, the way that the experiment was conducted wasn't sound enough or doesn't accurately capture what's going on. Other folks say that that's completely appropriate. It helps prevent institutionalization. But that's where that number came from for anyone who is interested. I would like to note that because Ohio is a managed care state and has a lot of managed care and is moving towards 100% managed care, it has elected to take advantage of this rule. However, it's only done it for mental health treatment and not substance use disorder. So this is an area of policy consideration moving forward, not only for the state, but for, in terms of the administration, but also the General Assembly. And the reason I'm highlighting this is that at one point during Ohio's budget process, there was language mandating that the state of Ohio pursue an IMD exclusion waiver. That was later removed, but obviously this is of mine, and this particular policy vehicle is something that the state has previously expressed interest in. So some things to understand here and considerations policy-wise. Number one, Ohio drug overdose deaths have increased 39% between July of 2016 and July of 2017. That is a pretty significant increase, and Ohio is one of the worst states in terms of opiate overdose deaths and also substance use disorders generally. Community-based alternatives help prevent institutionalization. So many of you who may be working in the behavioral health space or who might be providing services or consult with those folks, you know about behavioral health redesign, you know about all the changes that are taking place. It's important that there's some general connectivity between these inpatient alternatives, these inpatient options, and community-based alternatives to care. So, whether it's in the process of developing a waiver like this or just generally, some of the concerns that the federal and state governments have had currently and historically, it's how do you make that connection? I would also like to highlight that Medicaid expansion pays for about half of addiction services provided by Medicaid. So there's about $1 billion the state pays in terms of addiction. More than half comes from Medicaid generally, and about half of that comes from the expansion, around $280 million. So it's important to understand the interplay between policies, because a lot of the folks who might be eligible for Medicaid expansion or rather folks with addiction issues might be getting treatment through Medicaid expansion. So if they are required to do this work requirement waiver, how do those connections get made? How do they maintain their eligibility? What if they aren't in treatment, but they have an addiction issue? Do they have to get into treatment first before the eligibility, et cetera, et cetera? It's just important to understand that this is, these policies are all interconnected. Okay, so on to work requirements. Now, I mentioned before how the Obama administration's Centers for Medicare and Medicaid Services had a specific policy orientation that was coverage is a promotion of what Medicaid law is all about. The Trump administration's CMS, led by Administrator Seema Verma, pictured here, has a different orientation. She has put out language and guidance that basically suggests that when it comes to Medicaid, that personal responsibility is a activity which promotes health, and specifically has said, and this is the quote, "Believing that community engagement requirements do not support Medicaid or the objectives of Medicaid is a tragic example of the soft bigotry of low expectations consistently espoused by the prior administration." So what she's saying here, and what she has said, and what the department has said overall in regards to work requirements, is that we think that beneficiaries want to earn the benefit. We think that that process of earning is important. Obviously, we want to protect individuals who are too frail, but Medicaid has always traditionally been a program for folks who are disabled or elderly or children. It's not about just providing, sort of a free ride. And to those folks who, don't qualify in that way, we want them to participate a little bit more. We want them to have skin in the game. So Ohio has released its work requirement proposal. They did so on February 16th. They have a target implementation date of July 1st, which is a pretty quick turnaround. Something to note here is that it's limited to the expansion populations. So the folks who are a part of Medicaid expansion, this does not apply to the full 3 million of Medicaid beneficiaries. This makes sense. I don't think we're going to be violating any child labor laws here for kids enrolled in CHIP. But that being said, it's limited to the expansion, and it requires individuals to be exempt or participating in a work or community engagement activity. So what does this mean in terms of money and enrollment? Well, the state says over the course of this 5-year proposal, they will save about $571 million. I would like to note that that's about 0.4% of the entire Medicaid spend. So, $571 million, for me, that's a lot of money. For Medicaid, not so much. In terms of enrollment, too, they're saying that this will have a pretty de minimis impact, that only 1 in 20 individuals will likely be affected by these policies. I would like to just highlight here that this is some very effective messaging from the administration, but does not represent the reality. Work requirements affect all 700,000 individuals in the Medicaid expansion. And so there is something that needs to happen between that person and their eventual eligibility in order to maintain eligibility or coverage. So some of those processes may be automated, but other processes will require paperwork or engagement with providers or an evaluation by a county Department of Job and Family Services. There are a whole lot of other steps administratively that individuals may have to either passively or actively take in order to determine where they fall in regards to their eligibility here. And that's generally the issue. And so when we take a look at this, we understand that a lot of folks who would be eligible for this program or who would be considered, they're meeting a lot of these requirements, right? So the state has even kind of confirmed these numbers that you're seeing here from Kaiser Family Foundation. About 60% of folks are working either full-time or part-time, and those who are not working have good reasons to not work. They have some sort of major health issue that isn't quite a disability yet. They're taking care of a family member, or they're in school, or they couldn't find a job, right? So when we talk about here in a second exemptions and what work requirements mean, you can see that the state tried to accommodate for this variability and try to meet people where they are in terms of these requirements. So looking at the state law versus the state's proposal, first of all, the state law in Ohio Revised Code section 5166 something or other, it says that the Medicaid director shall establish a Medicaid waiver component under which an individual eligible for Medicaid on the basis of being included in the expansion eligibility group must satisfy at least one of the following requirements to be able to enroll in Medicaid as a part of the expansion eligibility group. They must be at least 50, employed, enrolled in a school or an occupational training program, participating in an alcohol and drug addiction treatment program, or have an intensive physical health care need or serious mental illness. The state's proposal tried to reflect not only what was in state law, but also the guidance that came down from CMS. And this is what they are saying. Individuals are exempt if they are 50 years of age or older, physically or mentally unfit for employment. They participate in the specialized recovery supports program, so they have a mental illness or a serious mental illness. They're caring for a disabled or incapacitated household member. They're pregnant. They are a parent or caretaker residing in the same house as a minor child. They're in school at least half the time, participating in treatment, et cetera, et cetera. A couple things to highlight is that when it comes to community engagement activities, they try to align this with the Supplemental Nutrition Assistance Program, or SNAP, or food stamps, if you will, and their work requirement around ABODs, or able-bodied adults without dependents. Basically, you know, if you are qualifying under that program, you're going to qualify for this. This is something that the federal government had suggested. And maybe you're participating in a work experience program. That also helps qualify you. Also, counties with high level of unemployment are exempted from this, something that you also see in SNAP. There's 26 counties that are exempted from the work requirement in SNAP. I think that there's a question here, and we're going to be putting out a piece here, I think, either today or tomorrow around the differences in potential racial equity around work requirements. Because, you know, you might be in Hawking County, let's say, or Hardin County, where there's high levels of unemployment, and thus you're exempt. But you might be in Cuyahoga County, and you're not exempt. But if you live in the city of Cleveland, the city of Cleveland might look more like Hawking than it does the rest of the county in terms of unemployment. And the demographic makeup between the city of Cleveland and Hawking is obviously very different. So there's a question of applicability of the law and whether it's equally applied on the issue of race. So we'll try to break that down a little bit further, but that's a consideration. Also, you know, if your status changes as an individual who's enrolled, you have to notify the state within 10 days. And there are good cause exemptions that are still available to you that will in part be determined by a county caseworker. So the state's trying to make accommodations here for individuals based off of that bar chart I showed you. But what else does this include? Well, first, self-attestation. So you have to sign a document saying, yeah, I meet one of these conditions. Then there's an appraisal. So a county department JFS worker says, okay, I'm looking at the facts, I'm looking at your case, I think you're exempt, you know, give me the following information, et cetera. Now, the state is saying that they don't have to do a lot of these face-to-face. I'd like to know more about how that's being operationalized, because I imagine if there is documentation missing, or if the county departments are doing this telephonically, there's still a workflow element, still a matter of time for those county caseworkers that is being used to make these determinations, which makes it more complex than what had existed otherwise. Also, there's this question of OIES reconciliation. So the Ohio Integrated Eligibility System tries to manage eligibility for SNAP, TANF, or Temporary Assistance for Needy Families, and Medicaid. How do these systems communicate? And for example, in a perfect world, these IT systems would overlap. It'd be very easy for county caseworkers to say, you are eligible for the ABOD work requirement, or you're meeting the requirement there, you're good in Medicaid. If OIES is not automated, how does that process work? If it's manual, or there's regular data management that needs to take place, how does that work? Is OIES even a part of this conversation? So I think that the eligibility systems, whereas once were much more simple. Are you in Ohio? Are you of a certain income? Are you between 19 and 64? Now there's all these other steps. Are you working? What's your income? How is the state managing adjusted gross income in the system, and how do they dedupe or deduplicate those two sets of data, so on and so forth. And then this other documentation piece, let's talk about what medical and medically unfit means. So let's say that you're an individual who believes that you can't work because you have some other issue that's getting in the way in terms of your medical condition. Well, you would need to then go to a licensed medical professional, have them fill out the form. That form would then need to be transitioned to the county department JFS worker. A JFS worker would need to make sure that you would then be eligible. Well, how does that form get developed? When does it get developed? How are people going to know that they need that form? If they don't have coverage, how are they able to make the appointment? In terms of hospital systems, you have questions about how do we educate our doctors and other medical professionals about this requirement? How does our financial services staff understand this requirement? Does the legal department have concerns about liability in case we accidentally provide coverage for someone who did not technically deserve it? This complication, I think, is at the core of some of the questions that we have as CCFs around how this would be operational. So some considerations. First, what's interesting is that the per member per month, so the average cost for the expansion population, is increased. This seems to conflict with other parts of state law, particularly around the Joint Medicaid Oversight Committee, which suggests that the Medicaid director pursue policies to decrease the overall per member per month of enrollees. The independent actuary for the state in JMOC has said that Medicaid expansion has a depressive inflationary effect on the average cost of the Medicaid program. So if the Medicaid expansion cost increase, does that increase the cost of Medicaid generally? Does that conflict with state law? I think that that's still a question. The estimates on disenrollment seem low. And what I mean by that is I think that the state is doing everything they can to accommodate the real world concerns of individuals who are enrolled in the expansion, and also the mandates set forth in state law and the guidance provided by the Centers for Medicare and Medicaid Services. But I would just say, for anyone who's been on a conference call before and heard hold music, technology doesn't always work very smoothly. So I would just suggest that one thing you might want to consider is that, this may work, but I think that there needs to be more fleshing out of how. How does this work? Where did they come up with these estimates? What formulas were they using? Additionally, costs. So what is the price tag to administer this program? In Virginia, for example, which is considering something similar, they said that the savings associated with disenrollment are actually outstripped by the cost to implement this new system of eligibility. I would also put out there that county departments, who often have unionized workforces, are going to have to renegotiate the roles of individuals who are going through this new eligibility process for folks. There's additional paperwork, training, call center time, communications and cross-training between folks who are determining SNAP eligibility versus Medicaid, et cetera, et cetera. I'd want to see more of those costs estimated and included in the proposal, because I think that will be key around the standard of budget neutrality. The question, is it legal? Kentucky has already, who's implementing something similar, there's already been a lawsuit that's been put forward. There are questions about whether or not this violates the Social Security Act. Is requiring work promoting health? Is this a violation of the Administrative Procedures Act as a result? Are there other questions about legislative intent in terms of whether or not this can be put forward? Can you even make eligibility in Group 8 something more flexible? Because it's in law and it says you shall cover Group 8, and the state has elected to do that, can you do that selectively? There's this racial equity issue we talked about. And what happens if benefits are inappropriately applied? So who is liable, and how does this affect managed care rates? So if individuals are enrolled, maybe they lied, or maybe they didn't have accurate information, or maybe their status changes and they didn't hit that 10-day window, but services were delivered, how does that money come back? Because you can't accept federal money for services that are rendered if someone is ineligible. And usually they go to providers to say, we need that money back, and that affects their rates, that affects revenue cycle management, et cetera. And for insurance companies, the managed care plans who are managing all of this, a lot of their capitation payment, the way they get paid from the state government, is built around how many people are enrolled. Does that change if there's an audit? There's a robust public comment process associated with these types of waivers. The first one of the 2 hearings that are mandated was yesterday. The next one will be on March 1st in Columbus at the Medical Care Advisory Committee in the Lazarus Building at 10 a.m. Public comments are welcome. There's information on the state's website about how to submit comments. And then there's also a federal comment period. I would say that the comment period that the state has put out there is that it's going to begin February 16th and end March 18th. One thing I'd like to note is that federal law mandates that there be 20 days in between the last public hearing and when the state submits its final application to CMS. So the earliest the state could potentially submit, I believe, is March 21st, but we shall see. So, okay, now on to 1332 as we sort of round third here. The budget required the director of the Ohio Department of Insurance to submit an application for a 1332 waiver. And this is not a Medicaid specific thing. This is about the individual marketplace or the Obamacare plans, however you want to term them. And this application will waive both the individual and employer mandates. The state contracted with Oliver Wyman to model scenarios under 1332, and some of the initial findings were that there were more insured in Ohio, mainly due to Medicaid expansion, but that also the individual market was smaller. Plans had been leaving. The Ohio Department of Insurance is submitting this because some of you might say, well, didn't tax reform get rid of the mandate? Yes and no. The federal tax reform did not eliminate the actual requirement to have health insurance. Instead, it says that there's no penalty for not having insurance. So the state is saying, okay, we're going to follow through on this. And the reason why the state is doing this is in part because the law tells them to, but also because, you know, they're trying to formalize what's sort of commonly understood through the tax reform proposal. I want to highlight that comments can be submitted to ODI by March 18th. You can see their email address here. You can Google 1332 Ohio Insurance, and you'll find their splash page on this. But I haven't found much information. There's a checklist that's on there about what they are going to try to submit. There was a 2-page document that circulated with the General Assembly around what they are going to submit, but there's not much detail beyond that. So I'll put it out there. If anyone has more information that I don't know about, feel free to send it along because I asked and searched for it a lot. But some policy considerations here. Initially, the director had asked for more flexibility in designing its application when they sent a letter to CMS in June. And they said they wanted to do something like other states like Iowa, where it'd be like a reinsurance program and where they could offer skinnier benefits than what is mandated in law through the essential health benefits and get rid of the individual mandate, et cetera. Federal law, it seems, does not allow for that. So, you know, Iowa withdrew its waiver. I think the state of Ohio probably then recalibrated its waiver. And in response, CMS basically had a few sentence reply to the director and said, we'll take your suggestions into consideration moving forward. So that's, I believe, why you're seeing a much skinnier version of an application. Like I said before, the information regarding the proposal and the public hearings is not well organized and easily accessible. I don't see anything online, and I don't know if it's my browser or not, but oftentimes I have to zoom out by a lot even just to click on some of their links. And then I think that there's a policy question of what purpose does this serve other than meeting the legal mandate in the Ohio Revised Code. If there is no financial impact on affordability, as the state has said, what are they doing other than meeting the mandate of law? And I think that that's really just the answer. They're trying to meet the mandate of law. So with that, I will now ask if there are any questions. Kate, do we have any questions from some of our participants?
Loren, there is a question about if Community Solutions has a summary or Q&A sheet that can be shared with Medicaid beneficiaries and people who have questions or concerns. I don't think we have anything like that now, but could you speak to resources for beneficiaries?
Yeah, that's a good question. We won't have anything
I'm sorry. I realized that I may have been on mute. Sorry. See, this is why eligibility systems will be tough. But long story short, the state is required to notify beneficiaries of these changes once implemented. We won't have anything that's beneficiary directed because we kind of just focus in on some of the policy issues, although we will be submitting comments on the state and federal levels, and I will be providing testimony on March 1st. There are a number of organizations who've looked into this, including Kaiser Family Foundation, the National Health Law Program, and others. I would say that anyone who is interested to consider submitting comments, and you can find some of those resources on our website and also on the state's website about how to do that.
There was a question here about sharing a link for comment information from the state. It sounds like some of that stuff is hard to find, and you've kind of shared the information that you have. But we'll give folks a few more minutes to formulate questions. If you want to type them into the chat box, we'll be happy to take your questions.
Sure, and I will put the link to the state's splash page for the waiver and the comment period in the chat box now, but you can also find that on our blog at communitysolutions.com, and just click blog in the upper right hand corner. But I will send that in the chat box right now.
Along with that, we'll also tweet out the link to that splash page at Community Sols on Twitter, so you can look for that in a little bit. There's a question about how the Medicaid waiver might conflict with the Social Security Act, Loren.
Yeah, and I think that's a good question, and I would say, I'm not a legal expert or an attorney, but a lot of this has been discussed in health trade publications like Health Affairs, and the National Health Law Program has researched these questions a lot. It basically boils down to the concept of what Medicaid is supposed to do, which is why you see this difference in framing between the CMS of the Obama administration and the CMS of the Trump administration. The question is whether or not these types of waivers promote the health of individuals who are participating in Medicaid. You essentially are saying that, the point of Medicaid is to make people healthier, to provide medical assistance through coverage so that they become healthier. The current administration thinks that getting a job is a health activity, that if you are employed, that it's going to make you healthier, that it's going to provide more benefits than if not. The last administration took the position of that coverage is primary in that equation. So I think from a legal standpoint and from a comments standpoint, a lot of potentially the evidentiary base of any lawsuit will be around this question of, do these programs not promote the objectives of health?
Loren, there's a question about if you have any information about what occurred during yesterday's public hearing.
I was not there personally, but I heard that for those who were able to attend, the room was hard to get to, first of all, but that also the state seemed receptive to any policy considerations that people wanted to put out there. As a part of the public comment process, the state has to describe how they are taking in public comments and how they affect their proposal overall. In the Healthy Ohio process, you didn't see many changes after comments were provided, in part because the state said there was a lot of rigidity in the Ohio Revised Code in terms of what we could offer. That's not necessarily the case here. So even in sort of conversations that Director Moody with the Office of Health Transformation has had, he says, we want to hear how can we make this better, what do we need to do, what are your concerns and questions. It was mostly just listening on their part. There wasn't room for back and forth, and I imagine that will be the case on the first. And I would imagine, too, the first will be much more well attended, even though there were a number of people who did go to Cincinnati, if only because the time between the 16th and the 21st with a 3-day weekend probably made it difficult for people to accordingly plan, digest, and interpret what was being said and offer thoughtful comments.
We'll give just a few more moments if folks have other questions, but also feel free to reach out to Loren individually. His contact info should still be on your screen.
Okay.
Well, I'd like to say that the reason there are no questions is because the presentation was perfectly presented to all of you and you have no policy issues with any of these 4 proposals. But in case you do and maybe you're shy, feel free to go to our brand new website, communitysolutions.com, and feel free to check out our resources around Medicaid. Like I said, there will be a number of pieces that will be posted around this and other issues relative to the program and other health and human services considerations. We also have a lot of research available to you. So one thing that you might be interested in as you're advocating generally is our community fact sheets, where you can find key pieces of information around, say, legislative districts, not only on the city and county level here in Cuyahoga and Cleveland, but also statewide. So you can find demographics on things like educational outcomes and teen pregnancy rates in congressional districts and state house districts, both in the House and Senate. So check it out. Let us know. Let me know if you have any questions. And of course, we will post this information online. And thank you for attending today's webinar.